Good evening, everyone, and welcome to the fourth installment of our Pharmacy Experts webinar series. The title of our webinar tonight is Administration of Naltrexone Injections for Opioid Relapse Prevention. I want to thank you for taking time this evening to join us for the webinar on this very interesting and important topic that describes how pharmacists can be access points for medication-assisted therapy with naltrexone for patients with opioid use disorder. My name is Dave Mott, and I am the Associate Dean for Advancement at the UW School of Pharmacy, and I will host tonight's webinar. This event is being sponsored by the UW School of Pharmacy Advancement Office, and I want to acknowledge and thank Alyssa Carnegie, our Alumni Relations and Advancement Coordinator, and Anna Reinhardt, our Event Coordinator, for their work marketing and producing this event. We have over 70 people joining us for tonight's webinar. So before we get started, I want to describe the process we will use for taking questions. First, the chat function is turned off for attendees. Second, due to the number of attendees, we will not be taking verbal questions. Instead, please use the Q&A feature on Zoom to type and submit your questions as you think of them. Since some of the questions may be the same across individuals, please feel free to click on the thumbs up icon to upvote for a question. During the Q&A session, I will read the questions with the most upvotes for Professor Ford and the panelists to answer. The webinar is being recorded, and we will send you a link to the recorded webinar along with an evaluation for the webinar. Please check the link for the recording starting on Friday. So let's get started. Our webinar this evening is a panel discussion that will be moderated by Professor Jay Ford, who is a faculty member in the Social and Administrative Sciences Division at the School of Pharmacy. Dr. Ford is an expert in implementation science and has been studying ways to improve access to treatment for patients with substance use disorders for many years. Dr. Ford and his research team at UW have been studying pharmacist-administered naltrexone injections over the past 3 years. Wisconsin is a perfect place to study this topic, since in Wisconsin, pharmacists have legal authority to administer drugs via injection. Dr. Ford's team has secured funding from the state of Wisconsin and has published articles describing naltrexone injection models in community pharmacies, best practices for naltrexone injection administration in community pharmacies, and cost models for naltrexone injection. Jay played a key role in providing information to the state of Wisconsin about pharmacist-provided naltrexone administration prior to the passage of Act 98. Jay is joined tonight by 4 pharmacists who are actively involved in providing naltrexone injections, and they will share with you their experiences administering naltrexone via injection. It is my pleasure to turn the program over to Professor Jay Ford. Jay?
Great. Thank you very much, Dave. So before I get started into the Q&A, I just want to take a minute to introduce the members of our panel. We're joined by Eric Jachthuber, who is a pharmacist at Bentley Pharmacy in Montello, Wisconsin. By John Lemke, who is the Community Pharmacy Managing Pharmacist at Streu Pharmacy Bay Natural in Green Bay, Wisconsin. By Thad Schumacher, who is a pharmacist and owner of Fitchburg Family Pharmacy in Fitchburg, Wisconsin. And then Jenni Villeneuve, who is a pharmacist and part owner of Murdock Hometown Pharmacy in Oshkosh. And Thad, Jenni, Eric, and John, I want to thank you for taking the time out to join us tonight. I want to start with a question to everybody, and I'm going to just start with you, Jenni, and then we'll kind of go from there. But I'm curious if you could kind of let the audience know not only when did your pharmacy start offering naltrexone injections, but more importantly, why did your pharmacy decide to start offering naltrexone injections?
So we started with naltrexone injections in 2017, and it was part of an initiative to not only provide naltrexone, but other long-acting injectable antipsychotic drugs. At the time, we had a really wonderful partnership that continues with Allay Health. Allay Health is a company that provides telepsychiatry. So in their patient population who was in need of an injection, they wanted their patients to be able to go to a local pharmacy and receive their medication injected by a health provider. And they chose, to partner with us. It has been an experience like no other. So the last 5 years have been not only a teaching tool for me, but a really nice partnership with other healthcare providers and with our patients.
Great. Thank you very much, Jenni. John, you want to kind of share your experience at Streu's?
Sure. We've been doing the injections at Streu's also since 2017. In our case, it was really a combination of a planning ahead business model for the future of pharmacy, as well as meeting a societal need, particularly when we find that so many providers in the area are fairly uncertain on how to approach getting these injections to their patients. So we really fit a unique niche in that regard as pharmacies.
Okay, great. Thank you. Eric.
Yeah, ours is a little different. We started basically when the pandemic started, and it was more of an opportunity. I had the training. We had the kind of the plan to initiate doing it when opportunities presented themselves. Locally here, we're in a community of about 1,500 people. Our not health department, human services department here was going to shut down, and they were providing many of these both long-acting antipsychotic medications as well as Vivitrol. And we had been dispensing them to them, and their nurses had been providing them. So when they got to this point where they were going to be shutting down, they didn't know what to do with these patients, and we were staying open, obviously. And so I offered to take those patients in, and that's what kind of springboarded us into what we were doing. So that's how we got started, and then we've kind of continued through the pandemic and picking up patients here and there with these type of services.
Great, thank you. And Thad.
Yes, we also started in 2017. We were also involved with LA Health to start off with, and continue to work with them, offering telehealth services in the pharmacy. It's a unique, like Jenni had mentioned, it's a unique access point where after a patient has a face-to-face meeting with the provider, then a pharmacist can actually come into the room, sit down next to the patient, and have like a three-way conversation about drug therapy and how they're going to move forward with both the oral drugs and injectable drugs. So that's been a very unique experience. And then we've continued to offer this service since 2017 and have become a place where providers send patients because either they have lack of access to other avenues to get the medications administered, or they just know that we'll meet the needs of the patient. Some of these patients don't have a great scheduling processes as far as showing up on time and coming to an appointment, and we know that going in, and so we offer a very flexible administration time.
Okay, great, thank you. Thad, just to kind of follow up, I'll start with you. Your conversation about working with LA Health. What can you kind of tell us about that relationship with them, as it relates to this service, including thinking about how you kind of made that connection, with them, and maybe even made connections with other providers in the community to offer this service?
Sure. For us, it's been providers who are have a roadblock. They want to provide care to their patient, and they don't have the ability to provide that care themselves. And that could be because they're seeing the patient in a telehealth situation, which they can't lay hands on the person that way. Or it could be that they are a provider that doesn't have staff to administer drugs. They don't have a nurse, or the staff they do have is busy doing all the other things that need to be done. And so they're desperate to have somebody answer their need for their patient. And LA was in that boat when we started with them. They had a service they wanted to provide. They had patients that needed care. They just needed someone to administer the medication, and that's where we came in. And I think the majority of patients that we've gotten are from providers who basically are referring them to us saying, help my patient.
Okay, thank you. John, is the situation similar or different for you up in Green Bay?
We seem to have a number of different groups that we work with. We did work with LA Health, but we have a different group of psychiatric nurse practitioners up here who faced that same challenge during the pandemic of having all their by telephone or video conference appointments. That really did drive up our numbers of patients whom we served. But we also had worked with our county health department and with a wide variety of different private prescribing offices here. It's kind of funny what happens when word gets around and the providers' offices are calling, wondering how to set this up for their patients who are also running into the same problems during the pandemic with not being able to physically see their patients.
Thank you. Eric, I know that you talked about starting yours up, kind of with the pandemic, and that you've been able to, maintain that, but also kind of established a few, maybe gotten a few new patients coming in outside of the human services department. Is there anything, unique about your situation in terms of developing the relationships with providers?
Well, it continues to be a work in progress. Unfortunately, in small communities such as the one that I work in, we don't have any, there's no provider network here. So the pharmacy is the source of healthcare, which again, provided great opportunity for us during the pandemic. But then also during the pandemic, it occupied a great deal of my time and our efforts. And so now we've experienced this in the last, knock on wood, 2 or 3 months where things are letting up a little bit. So now the ability to revisit some of these initiatives, like expanding some of the medication injection initiatives, is on my kind of forefront. We have many of our patients that get prescribed this come from areas, say like Oshkosh, where Jenni is, or down in Madison. So we have patients that we got to try to get the word out that they can get it locally, or that providers within a certain area have the ability to have their patients get these services without having them travel great distances to get those. So I haven't done a ton beyond just the logistics of what the last couple of years have been, but those are kind of my plans going forward with it.
Okay. I wanted to follow up just real quickly to something you said at the beginning in the introduction, Eric, and that is, you said you got training on how to do this. Was that the training that's offered through the School of Pharmacy and the kind of professional practices? Is that where you took your training for this?
Yep, exactly. So it was that UW course, I think a 1 CE course. I've been immunization certified for years. So I did when I went from a community chain pharmacy practice to independent practice. That was one of the first things I did, again, to make myself available for those services. So yeah, but that's exactly the training I did.
Okay, great. Thank you. Jenni, just to follow up in a slightly different question about the provider relationships, what advice, would you have for others, who may be doing this, or are thinking about offering this service, for maintaining the relationships with providers? And I'm also curious whether or not you're doing any of this under, a collaborative practice agreement.
I am. I have a collaborative practice agreement with a local physician who was family practice, and his practice kind of evolved into treating patients with opioid use disorder and alcohol use disorder. He is also the medical director at a rehabilitation facility down the road from my pharmacy. So I see patients of his both from that inpatient facility and from his practice at one of the health clinics here in town. Our collaborative practice agreement allows me to administer Vivitrol to his patients, whether or not I have a current prescription on file. And then he and I iron out the details afterwards if a patient is truly in need. I've had a number of instances where patients have come in and said, I was very close to using last night. I know I'm not at my 1 month mark. I don't have an appointment to see Dr. So-and-so. But I feel like if I don't get this today, I'm going to go out and use tonight. And that collaborative practice agreement allows me to take care of the patient and to communicate with, my healthcare provider afterwards. It's been a wonderful partnership. His nurse is incredibly busy, and I know that she also is very appreciative of the fact that she doesn't need to administer all of their injections to all of their patients. Through that relationship with him, like I said, I see patients from the rehab facility down the road. Also, he is involved in a community grant that we've gotten through the state of Wisconsin here in Winnebago County. So I have, like Eric, also been working with our human services department and one of the physicians there to provide naltrexone injections to patients who come to me through the court system and through the DOC. And then those provider relationships also kind of branched out to a relationship with Rogers Memorial in Appleton, as they have patients in both their day programs and I believe in their IOP programs who were in need of these injections and had no place to go. So I would encourage pharmacists out there to continue communicating with healthcare providers about the service you're providing. It is very apparent to those providers the value that we provide. They just need to know that you're there.
Great, thank you. John or Thad or Eric, do you have any thoughts about whether what do you have a collaborative practice agreement, and if so, how that's working, or any other advice about maintaining the relationships with existing providers?
I can speak a little to that. I think that the frequent communication when patients aren't showing up is a part where our providers appreciate hearing about that as much as knowing, when the injections were received. It certainly helps us all coordinate care and stay on top of our patients. And where I am, we do a little more, that's a standing order than it is a collaborative practice agreement. For providing the injections, but I don't know if I always want to have the ability to have it basically be prescribed at my discretion here, simply because I do have certain patients that can be litigious, we'll say. So
yeah,
it's a little area of protection for me to know.
Fair enough.
So we don't have a collaborative practice agreement to give administer the medications. We do have a collaborative practice agreement in order to offer a urine screen. We don't always urine screen every patient prior to dosing them. Mostly it's only for the first dose, and that's if they haven't been screened previously. And then the last 2 years, pharmacists have stepped up to the plate, and you have done great work in the community. It's really important for you to keep in contact with all the departments of health people that you have talked to over the last 2 years, who have answered your phone calls and you've answered theirs. Send people an email, remind them that you're there and the services you can provide, and that goes a long way, I think.
Great, thank you.
Yeah, and no collaborative practice agreement here, or nothing set up as of right now. And again, the thing that really, again, as I mentioned before, that got us going is that partnership with human services, and then through this pandemic with our county health department as well. Our community is the county seat, so all of these people are right here. And so it's been a great communication and great resources back and forth both ways, and been mutually beneficial.
John, I want to start this next question with you for a second. And, we talked about, we've talked about the injections, right? I'm wondering, if you can kind of describe a little bit, the process, involved in providing the injection. And then, as I kind of alluded to, in the questions that I sent you, things like, how do you kind of figure out the best way to, position the client, figure out where to give them the shot, and things like that. So could you maybe just talk to people about that process a little bit?
Sure. I'd even back it up to where we are communicating with the physician's office about what we're going to need, say, lab-wise, and to educate our providers is what to tell the patient's expectations are going to be. Frequently, we have our patients come in not expecting there was going to be a urine screen, or not understanding the duration of the appointment, especially for the first one that comes in. Our process is one where we also want to stay on top of the patient with frequent communication to remind them of the appointments, to remind them that if they don't show up to the appointments, they're going to have to wait for 45 minutes for the injection to warm up. As far as the process of rooming a patient and providing the injection, we do this all in, of course, the closed door room, removed from the rest of the pharmacy, so the background noise is as minimal as possible. We're fortunate to have that set up where we are, and the conversations can get quite personal there, so it is important to have that set up. And the administration itself, the advice I give our patients, I was given by the nurses who work for the manufacturer, who have given many of these, that do what we can to make it as comfortable as possible for our patients. We don't have a place, I imagine most of us don't, where a patient can lie down. So they are doing these injections either leaning over a chair or leaning up a wall, table, whatever. But we advise our patients to put their weight on the foot that is on the side they're not getting the injection, and to help prevent that muscle from clenching up and causing more pain for them, to place their other foot behind that foot where they are putting the weight, and stay on their tippy toes there. It does allow for it's harder for them to clench up, and it relaxes the muscle that way.
Great, thank you. Anybody, Thad or Jenny or Eric, anybody else want to kind of weigh in on that process, and is it kind of this, are you guys taking a similar approach?
Yeah, the closed door space is very important to have for this process, because the people are going to be, distrobing a part of their backside for your injection, and then also so you can talk about those kinds of things without the whole pharmacy hearing it. And then in terms of we don't have a lot of space for our closed door rooms, and we tried to put a table in there for them to lay down on and just couldn't make it work. So we also use the stand over a chair method.
Okay. Eric or Jenny, do you have anything you want to add to that conversation at all?
No, we basically follow the same type of thing. Again, no room for laying down, and so again, we have them lean over a chair and do similar technique as discussed.
Okay, great, thanks. Eric, I want to start with you with this next question, and that's just kind of, I kind of jumped ahead a little bit, in terms of talking about the injection, but, prior to the patient, actually showing up for the injection, are there any services that you're providing to them, whether it's, helping them obtain benefits, to cover the cost of the medication, or, maybe behavioral health counseling? Are there any particular services you're offering prior to them coming in to get the injection?
When it applies, yes. The vast majority of ours have been state Medicaid patients. So that part of it is not, usually the cost aspect of it doesn't come into play. we don't get involved anything other, prior to their visit. I make sure I have a prescription, I have the documentation that the state requires on that prescription. And then obviously product in stock and have everything prepared. So when they do come, I've got everything lined up. So it's an efficient process for them. But as far as anything else prior to that visit, I don't have anything structured currently. I don't want to jump ahead, but then when they do arrive, then there is a series or kind of a regimen that I go through in talking to them, follow-up questions from their last, injection, and then leading into this injection as well. So, but yeah, that's kind of the process we have leading up to it.
Okay. Can you say just a little bit more about, what you're doing when the patient arrives, those questions that you're asking them?
Yeah, it's kind of what I do is I don't have a high number of patients, so I kind of keep a little folder, simple documentation of, and I put it all in my electronic, charting as well. But just where we did it last time, did they experience any soreness, any other reactions, how they felt, this past month, as far as, urges and relapse and any of that type of stuff. So those are the main things that we cover, is any issues from the last one, and then how they're doing as they stand there today or leading up the few days leading up to their appointment today.
Great, thank you. Jenni, kind of the same question, and I'm curious. I know, when we started talking about this, that I think, you and I know Thad probably had some relationships with LA Health where they were providing, behavioral health counseling, prior to the injection. But I'm wondering if you could talk about kind of the process there at Murdock, and whether or not that behavioral health counseling is occurring, in the pharmacy or kind of occurring outside.
I would say for the majority of my patients, it's happening outside. I think I missed a calling in life. I would love to be their therapist too, but I don't have the time for that because I have prescriptions screaming at me out in the pharmacy. I personally love my time communicating with my Vivitrol patients. But as far as any type of behavioral therapy offered by the pharmacy or through the pharmacy that isn't currently happening, it's definitely something that I have been interested in looking into in the future, just to really make, come full circle, and have the patient's care be a little bit more comprehensive and a little bit more centered to one physical location.
Great, thank you. Dad, I know that you were doing some counseling with LA, early on. I'm wondering if you're still doing that, and if so, what does that look like, kind of?
Sure. So our communication with the patient is about the same as what Eric described. You're asking them how things are going, how the medication's working, did they have any problems, that kind of thing. The other thing we offer is if the patient's on any oral medications, we sync their oral medications to their Vivitrol dose, so that when they come to the pharmacy, they pick up all their medications and they're not coming back 3 or 4 times in between shots. Some of these patients, the pharmacy is a trigger. So we want to not have them come to the pharmacy if they don't need to.
Okay. But are you doing anything telehealth wise in terms of working with LA where the patient will do the behavioral health, at Fitchburg, or was that kind of a pre-pandemic life?
It was definitely a more pre-pandemic situation. The rules for their engagement with the patient changed with COVID, to a point where they could see them on their telephone or computer, which then eliminated their need to be at the pharmacy. I don't know if that will ever change and go back to the way it was, but okay. For now, we don't see the patients except for just the injection.
Okay, great, thank you. John, kind of a follow-up to that. Once your patients, have gotten the injection, can you kind of just describe to folks what activities you're engaged in, after the injection?
Well, the first would be if it's a first injection, there is a patient monitoring physically for any kind of bad reactions. I did have one person have an anaphylactic reaction one time to it. Following that, we write a SOAP note basically, and that is what gets sent back to the prescriber. I saw in the chat there was also a question about the difference between a standing order for injection. I do ask all of the providers to write pharmacy to inject on the order for the medication itself as it comes in. Following up with that is if a patient is a no-show or reschedules, I do notify the physician about that. We have a 7-day follow-up after the patient's first, and the only time we have this phone call to see how they're tolerating the medication, basically treat it like a specialty medication in that regard. And then outside of that, it's really more of when the patient is there that we're asking the questions about, do you have that support structure around you? Are you going to meetings? Who is your counselor that you're seeing? Do you need help getting a recovery coach or something like that? So it's not so much the after the fact, that's more of a communication with the provider.
Okay, great, thank you. Eric, what about in your situation? What kind of follow-up activities are you doing?
Yeah, we do, again, a similar thing with first-time folks is that we will reach out to them again after a week. Same thing, just general follow-up to make sure there wasn't any issues that arose that we weren't aware of. I always, I should say, offer to have them call at any point if they're experiencing problems, a reaction, anything that they that we deem to be kind of unusual or would need further attention. Then I basically do have a follow-up. So with my patients that are county, I just have a simple email with certain things that I follow up with them, letting them know that they showed up, summarize what our conversation was when they came here. And that, so it's a very brief email that I send that it contains that essential information so they know that the patient showed up on their end. When it is a few of the outside providers, I put something together and then fax it over to their office. So again, a similar type thing that this patient showed up this day, this is what they reported, this is what we discussed. In that if they have any questions to give me a call. So again, it just sends some documentation over that they did receive that shot.
Okay, great, thank you. Jenni, I want to circle back to you to kind of shift gears a little bit to kind of looking kind of going forward. And I guess the first question I have is, what have been some of the most significant facilitators for Murdock Hometown Pharmacy to be able to offer this service? What has really kind of made that work for you?
Well, going back to one of the initial questions you asked, is having those relationships with other providers in the community has probably been the biggest facilitator. It allows for them to do their job and for a patient to establish a relationship with us at the pharmacy, making their care in the hands of more than just one individual, than just their primary care provider. I also feel that working with my staff, who are incredibly open-minded and have really welcomed this as part of our just everyday pharmacy workflow, has really facilitated the ease into being able to do these injections. I always tell my patients when they walk in, if you didn't schedule, we will fit you in. You may have to wait some time, like John said before, just to let the medication come up to room temperature. But my staff is incredibly welcoming, and we tell our patients this is a no judgment zone. And I think because our patients know that we're here for them and we're here to be part of their recovery, not be in charge of their recovery, it allows patients to feel comfortable here. And I think they go tell their other colleagues and friends in the recovery community, I know this pharmacy over, on Murdock Street in Oshkosh, and they will be willing to help you. And that I think has really been probably the largest facilitator in being able to do these, is having a no judgment zone and having patients tell their friends.
Okay, great. Thank you. Dad, what about from your perspective? What do you think are some of the biggest facilitators?
Well, a lot of, I'd echo a lot of what Jenni said. I think if you treat people who don't get a lot of respect generally with respect, then they notice that, and they tell the other people they know about it. And then one thing that I was talking with our staff today about, who facilitates this. And one big thing we've had happen here in Madison is a lot of social workers bring the recipients to the pharmacy for their appointment. So they drive them there, they make sure they're there on time, they make sure that they're ready to go. And I think it makes their job a lot easier as the social worker if these individuals get their medication. And so they have helped facilitate a lot of work for us.
Great, thank you. John, what about from your perspective? What are some facilitators?
Well, I think the accessibility of pharmacy is something that really is underappreciated, or at least not recognized as an advantage. As Jenni was saying earlier, the ability to squeeze someone in, especially when they're ready to treat, is something that makes it so much more appealing to use a pharmacy from everybody's perspective, I would suppose. And it's such a big need, a societal need, to have this and to have it readily accessible, especially for the patients that are likely to need this service. There's a lot more limitations, transportation limitations, things like that. So a stigma that would go along with that, as far as where you might be needing to seek the ride to. Everybody goes to a pharmacy, so that has certainly helped move things in our direction there.
Great, thank you. And Eric, do you have any thoughts about facilitators for you? I mean, you're kind of in a different environment, so.
Yeah, and Thad kind of hit on the big one for us, and it is those social workers, because many of the communication for appointment scheduling for the patients do go through those human services workers or those social workers. So a lot of our communication and my communication following up filters through them as well. And if somebody's running late or something's going on, they track them down, they get them in, they follow up and do some of that type of stuff that helps, again, with the adherence and help keeping people on track.
What about, while you've got the floor, Eric, what about barriers? What are some barriers to some of the bigger barriers to providing this service?
Well, for us, really the barrier is just getting it out to those providers, finding providers that match with what we're providing in my area, in my setting. Again, everybody else, we've got Green Bay, Madison area, Oshkosh. I'm in a community of 1,500 people in a county of 15,000 people. So I have, very spread out, very rural population. And again, many of these services are not out there offered unless it's through the court system in communities like this. So finding out, the providers that are prescribing it or want to prescribe it, and then getting that information, getting that disseminated out there, so that, again, we can help patients in these more rural areas to know that, it's not a service that you really can put an ad in the paper and say, come on in. It really is finding those niche providers and making it known that you're doing it, you're willing to do it. And because of what pharmacies and pharmacists do and how we practice, that it's a logical match.
Okay, great, thank you. John, any barriers that you've encountered?
Well, our barriers are really the 3 S's here. It's someone, silos, and insurance. You gotta have the people to be able to do this. You can't really underestimate the time it takes to administer this as part of workflow, especially if you're running a lean operation with only one pharmacist at any given time. It's a coordination of care issue too. Oftentimes, I mentioned earlier, and I found this to be, one of the bigger advantages in communicating with providers is, keep in mind that the prescribers frequently don't necessarily know the process of what needs to be done. So helping anything we can do to break down those communication barriers. And when it comes to treating, of course, addiction, it's not something that's just the drug is going to do. There's a lot of different players, a lot of different factors. So with everyone operating in those own silos, that does make it harder to coordinate, but it's not impossible. And my biggest frustration is with some insurance plans that will require, this comes from their specialty pharmacy. This has to be mailed to the provider. And, as talked about earlier, when someone's ready to be treated, one more day waiting for a drug is one more night you can use. And that compromises care. I absolutely don't think it should be allowed to require that this drug come from some insurance.
Yeah, I hear you. Dad, any thoughts about barriers?
So the biggest barrier is insurance. We have insurers that won't pay for it in the pharmacy, and we have people who need it. They come to us. I say this all the time, that if someone walks into my pharmacy and asks me to do something, they probably stopped 4 other places before they got to me. And so we've run our pharmacy on being the person that can answer those questions. And here we are, able to provide medication for someone, and their insurance will not allow it. It's mind-boggling. That's probably the biggest one. Transportation is probably the other big barrier for our patients.
Okay. And Jenni, anything you want to add in terms of the barriers?
I was just going to bring up transportation, which is what Thad just brought up. I see that happen very often. And then, like John said before too, I'm a one-man show 3 days out of the 5, weekdays. So for someone coming in for a first injection, especially, I would love to sit down with them for 15 to 30 minutes and really talk about what to expect from the injection, what this whole process is going to look like moving forward. And sometimes I just don't have that time. So I would say, as with everything in life, time is always a barrier.
Okay. So I'll just open this next question up to anybody on the panel who wants to respond. And that is, we've talked about, facilitators and barriers, but what advice, do you have for someone who's listening on the call today or going to be listening to this webinar later on, who's never done this or are really maybe thinking about offering naltrexone injections? What advice would you have for them? I'll just open it up to whoever would like to respond. So.
Well, I'll just start with mine, because mine was less of a methodical plan and more of a opportunity. So like anything else, again, and not to continue with the rural pharmacy bit, but I always look for opportunities to take care of people, opportunities to expand into a service, opportunities to do things that we can do that's unique as pharmacists, because patients here, there's going to be patients that are going to benefit from it. So many people out there, it may seem like an intimidating service to provide, but once you get that first one out of the way, it's very easy. It's very simple. It's very rewarding. Patients appreciate it. So it's just something that when the opportunities are there, take them, no matter what it is, whether it's this or anything. Take those opportunities to provide those patient cares and patient services, so that, again, that's what it's going to lead to.
Okay, great. Thank you. Anybody else have any thoughts about other advice you would offer someone who wants to do this?
I would say that when it comes to the customers, one, don't underestimate how much communication you'll need to do with your internal customers, having buy into this, and maintaining the work atmosphere you want. It's going to be important that there is an understanding across the organization of just what kind of commitment this is. and how it is going to pull some people out of workflow. And it will seem like you're not doing your job when really you are. You're simply not just going to do it by script count. The other thing would be to establish in the external customer an appreciation of the fact that this is no longer a purchaser and a purveyor of goods situation. This is patient provider. You're walking into something more like a doctor's office than a Wendy's here. So establishing that with your clientele from the word go, and I think you can authoritatively do that here. So
Great, thank you.
So I think that as Eric said, you got to take opportunity when they come along, and it's going to be daunting. It's going to be like, I didn't get trained to do this in pharmacy school. All those things are going to come rushing through your head. But then you got to stand back and go, I can do this. I am trained. I'm a healthcare provider, a professional, and then tackle it and move forward. In terms of having us have provider status and being able to bill for these services that we're providing, I think it's important to note that all of us here on the panel are not getting paid for the service past the drug. And if you are, let me know, because I want to know how to do that. But someday we will get paid for them, and having these processes established and in working order when that happens is going to put us at an advantage.
Great. But that's a good lead in to my last question I have for you guys before I kind of open it up to the questions from the members of the panel or the audience. And that is, what do you really think is going to be the impact of the recent passage of Act 98 on, pharmacists to be able to provide this service in the future? Any thoughts about that?
I think it helps momentum. I think it will be the opening of a door for financial reward for doing so, and I think that might just be the first crack in the dike as far as it goes with that. It's going to help with all other aspects of educating that this is available, allowing a way for us to more broadly show that we are a very logical place for this service to be provided for this and other services, such as the long-acting antipsychotic injections and whatnot. And I see it as a great momentum starter.
Okay, great.
I agree. I think that with the vaccinations for COVID over the last year, people have recognized that pharmacy is a place that can meet a need and solve a problem. And I think that this is just going to give us the opportunity to work with providers to sign collaborative practice agreements, to do other things that we don't even know that we can do right now. So I think that's great.
Great, thank you. Eric or Jenni, any thoughts from you about Act 98 before I kind of turn to the questions from the audience?
Well, I think part of that's in the back of all of our minds, at least the individuals that are here on the panel. That's one of the reasons why I, have been doing it and try to do it and try to expand doing it, is that, like the other guys alluded to, that there's hopefully it's a means to progress, and that it pushes it forward. And when the opportunities are presented, that, we've got the blueprint.
Okay, great. So I'm going to start with kind of just the first question in the Q&A, and just open it up to anybody on any of the panelists who want to answer. And that is, has it been difficult coordinating screening / labs, prior to administration, specifically, urine screens, LFTs. So do folks does somebody want to take a stab at, their experience with that?
So I do a urinalysis before each injection. And again, we go into this telling the patient this is a no judgment zone. If they come up positive for something else, I am not the person to stand in judgment. I just want to prevent an emergency situation in my pharmacy. So I do that UA prior to every injection. I do ask my patients if they have had any blood work with their physician prior to being at the pharmacy to check their liver function. I get about a 50-50 response with, well, I know they drew some blood work, but I'm not really sure what they were looking for. So I just kind of go through with them what sorts of things to look out for when they should be following up with their physician, what sorts of things they should be, asking for. But the only true lab work that I do here at the pharmacy and record in our pharmacy system is just the UA.
Okay. Any thoughts from anybody else? Have anything they want to add? Otherwise, I'm going to shift to the next question, just kind of in the interest of
Quickly, I
time.
would say
Yeah.
that be sure to let your patients know that the urinalysis is strictly for their protection. It's not a gotcha moment where we're going to share with your provider or anybody else that, oh, we found THC in the urine. I don't care about that. I care about your safety. I'm looking for opiate presence. That's it.
Okay. All right. Again, kind of just opening it up to, the panel. Tesley asked a question about, could you share some information on prescription versus order to inject? Well, I don't know if anybody has any thoughts about prescription versus order to inject.
I've got a couple of providers that have just standing orders that we can administer at the pharmacy, but I prefer for documentation and insurance audit reasons to have the prescribers write on every single prescription pharmacy to inject.
Okay. All right. Okay. The next question is kind of, it's talking about, when this excellent service that you guys have been talking about is not covered, by insurance, what do you do? Do you ask the client to pay? Do you turn the clients away if they don't have insurance and they're not able to self-pay? Any?
So yes, we turn people away if their insurance doesn't pay. We basically work with their provider to let them know that they need to find another avenue. A lot of times we're talking to the provider before we even talk to the patient. So it'd be hard for, I can't even remember a time when a patient was standing in front of me and I had to say, no, I can't give you this medication because it's not paid for by your insurance. That would have been found out before they ever scheduled an appointment.
Okay. All right. Jenny or John or Eric, any thoughts about that from your perspective?
The times I will charge a fee is if we do run into a situation where the insurance company requires that the Vivitrol be sent from whatever pharmacy they prefer, in which case there is an administration fee. I do recommend that price be set quite high, and maybe there's a discount pricing plan that your patients can sign up for so they can take advantage of a discount rate such that you can charge less. For example, I'll charge $35 to someone, but they have to sign up for our Streu RX Savings Club because I'm not going to establish a usual and customary price so low. So as when it comes time for us to bill, I'm getting squeezed out of the money. So
yeah, understandable. Okay. Any other thoughts about that? I do know that other pharmacists that I've talked to, especially maybe patients coming from the treatment courts, might charge a small kind of administration fee, $25 or $30, depending on the situation, for the patient. But I think that's probably rare. The one other question that's in the Q&A right now is just people are interested in about how many injections do you do a week are you providing to patients? So John, I'll start with you and then we'll kind of, hit everybody else in terms of the number of injections you're doing.
When it comes to Vivitrol, it seems to be a waxing and waning number of the number of patients we had. I've had maybe as many as 15 to 20 active patients at a time, sometimes as few as 6. So Vivitrol, somewhere between 2 and 6 injections a week for that. A lot more of ours are the long-acting antipsychotics.
Okay. Dad, what about you?
Same. We don't see, we see a majority of the long-acting antipsychotics for our injections, and we do about 5 to 6 injections per week.
Okay. Jenni?
Again, I echo that it does wax and wane. I would say I've done as few as 0 in a week. I've done as many. I think last week I did 7. It really, there are many factors that kind of play into it.
Okay. And Eric, what about you? I know your situation's different, but I'm just curious how many you're kind of doing on average a week.
Yeah, yep. So I guess I'll put mine in terms of monthly. So I've had as high as 7 or 8 in a month, and right now I'm probably down to 3 or 4 right now. So yeah, just like everybody else, it does seem to go in through feasts and famines.
Okay, great, thank you. Dave, I'm not seeing any other questions, in the Q&A, so I guess I'll turn it back over to you at this point.
All right. Thank you, Jay, and thank you, Jenni, Eric, Thad, John, really appreciate it. And thank everyone for attending the webinar. And at this time, please join me in thanking Professor Ford and the panelists with a nice silent round of applause. Okay, so please look for an email with a link to an evaluation survey so we can obtain your feedback about tonight's webinar. And in other alumni engagement activities, please check out the latest edition of Discover RX, the School of Pharmacy's digital publication. Please be on the lookout for information about regional alumni engagement events this summer. And also please consider donating to the School of Pharmacy's Student Success and Support Fund to help our amazing pharmacy students. So thank you, everyone. Please stay safe and healthy. Have a nice evening, and on Wisconsin. Good night, everyone.
Right.